In this part, we are more concerned about the surgical options, and we'll be discussing about the different procedures. And we're not more concerned about the draining procedures because they're most of the time performed by the interventional radiologist or the gastroenterologist. So in this part, we will be discussing about the surgical treatments depending upon their stage of the tumor and depending upon their resectability and the classification system. So first of all, if we talk about the hilar cholangiocarcinomas, so the treatment option is like you can go for local resection with negative histological margins and restoration of the biliary entire continuity. Now it entirely depends upon the tumor extent, like how much of the part, how much of the common hepatic and confluence is involved, and then if you have to do the cholecystectomy, or you have to do for the hepatocoagulanostomy, and that's more or less same thing, the hepatocoagulanostomy. And if most of the time for the tumors which are intraductal, then you do the hepatocoagulanostomy. But for the hilar tumors, if you are successful in doing the whole of the total resection with the negative margins, then you can go for the cholecystectomy. So the first option is local resection with the negative margins, and then obviously restoration of the biliary entire continuity. And the second option is hepatocoagulanostomy, and sometimes you have to go for the hepatocoagulanostomy with partial hepatectomy. And in these particular cases in which you're doing a partial hepatectomy, the indication obviously would be the involvement of the liver parenchyma. And sometimes if whole of the tumor is involved, mostly intraductal tumors in which the rest of the part of the liver is also involved, and you may end up in the liver transplantation. And those tumors which are just involving a limited part of the lobe, you can do the en bloc lobectomy. That can also be performed in case of the hilar cholangiocarcinomas. So remember the four important treatment options for the hilar cholangiocarcinoma. One is a total resection, keeping in view that you have to attain negative margins. Obviously, you have to resect the wide resection, and the tumor margins that should be left, 4 centimeter of the tumor margins should be safe of the disease, and you can do the cholecystectomy. And then hepatocoagulanostomy, and then hepatocoagulanostomy with partial hepatectomy, and then en bloc lobectomy can be one of the procedures that can be used. So talking about hepatocoagulanostomy, you can see here, this is actually the part of the bile duct, and this is the jejunal loop. So what you do is that you have to create a space, or you have to give a small incision in the jejunal loop, and then you have to do the suturing. It's anastomosis, and it's the end-to-side anastomosis. So you're using the end of the common bile duct or whatever, if we talk about the hilar, the common hepatic, and then you're combining it with the rest of the portion of the loop. So this is actually the anastomotic technique. It can be single layer extramucosal end-to-side anastomosis, or it can be through and through double layer anastomosis. Okay, so it entirely depends upon your expertise, but I usually prefer that you should go for extramucosal anastomosis. So you can see here as well that this is actually the you're doing the inside out and outside in, and you have to create the anastomosis, which is the end-to-side anastomosis for that. So this is actually the final picture of the hepatocoagulanostomy when you're done with that. Some other pictures, which this is actually, you can say, a cholecystectomy, which is a Roux-en-Y. Why it's called as Roux-en-Y? Because you're creating a Y loop. Okay, so what you do here is that this is the duodenum. Okay, so you have to just close one part of the duodenum, and you're resecting the whole of the biliary channel, and you're just for the tumors which are distal, and for the hilar tumors, this is the confluence, and this is the common hepatic. The rest of the part is being resected, along with the duodenectomy is also performed. So the part which is left here the second part, you do a choledochojejanostomy here. Okay, so this is actually the part of the duodenum, and the other loop of the duodenum is closed, just like here the stump of the duodenum is closed, and you have to access the loop fixed to fascia and mark with a radio opaque clips, and you for a better vision, and you have to go into the lesser momentum to go retroperitoneal. Okay, so after that you have to bring this jejunal loop here, and this is the first part of the duodenum, and the remaining portion of the duodenum, this is actually you're closing one stump, and the other stump is here, and all the way you are fixing it here. So this is actually Roux-en-Y choledochojejanostomy. So one is combining here, and this is the other procedure, like you're doing choledocojejanostomy, and you're doing jejunojejanostomy, and you're doing a jejunogastrostomy. This is actually a kind of a pylorus preserving surgery. This is pancreaticoduodenectomy, actually, in which you're doing. So you can create all the way. You can go for like this. You can create the Y loop choledocojejanostomy, in which you're combining heat here, and then the jejunal loop is combining with the rest of the remaining portion of the bile duct. And then you could, or either way you do it here, combining, creating it. This is a jejunojejanostomy. Okay, and just like here, the duodenum is removed and the part of the loop is closed here, and you do a jejunojejanostomy and a choledocojejanostomy, and or you do a jejunogastrostomy and jejunojejanostomy, and you do a hepatocojejanostomy. These can be the options we are available with that. Now, and some tumors in which different lobes of the liver are involved, and it's not possible for you to spare, then you can go for the partial hepatectomy. You have to combine it with the hepatocojejanostomy and partial hepatectomy. And there's another surgical option, which is the en-bloc caudate lobectomy, which is less invasive as compared to the procedure performed like partial hepatectomy. So in lobectomy, you're just removing the segment or lobe of the liver, just like that. You can see there are different approaches. You can either follow the anterior approach, you go for the right approach, you go for the left approach. So this is the actually caudate lobectomy. This is the caudate lobe, and you have to mobilize the ligament, because the different lobes, the triangular ligaments, right and the left triangular ligaments, are actually important in connection with the liver, with the abdominal wall. So you're actually combining these here, and then that's how you can do the en-bloc caudate lobectomy for the tumors which are limited to the different lobes. Already discussed about the Roux-en-Y choledocojejanostomy, but let's just this picture is more clear. This is the different part. This is the involvement. Okay, so you can see here, this is the stomach, and although it's coming here, duodenum, and this is actually the jejunal loop. Okay, so you're doing a choledocojejanostomy and jejunojejanostomy. Okay, so this was the remaining portion. You divide the common bile duct here. This is the proximal end, this is the distal end. The distal end is closed, you ligate it, and then proximal end here is anastomosed by, again, end-to-side anastomosis, and you combine it with the jejunal loop. That's how you get rid of the whole of the part in the other part of the duodenum. You do just close the stump, and you do a choledocojejanostomy, and you do a jejunojejanostomy. So this was the remaining portion. This was actually the, you also do a cholecystectomy for that, and obviously the cystic duct along with the proximal cystic duct and the gallbladder, they are being removed, and this is the just distal part. You just ligate the distal part of the cystic duct, and you just have to anastomose the remnant bile duct, which is the choledocojejanostomy. So this is the roux limb, and this is actually made from this is Y and this is roux, and it's actually made from the jejunal loop. You all the way you have to use the jejunum for the choledocojejanostomy and for the jejunojejanostomy. Now, the most important procedure for the advanced tumors, which are involving almost the whole of the part of the bile duct, like intrahepatic, hilar, and the distal part, then you have to do the Whipple's procedure, which is a very, very long procedure. And, for even those the smaller setups in which this procedure is not routinely performed, the mortality rate is very high and success rate is only 25%. In post-operative morbidity and mortality with the Whipple procedure is very much high, but those setups which are actually running 20 to 25 procedures per year, they have a better survival rate and they have a good prognosis with that, and almost the death rate is as less as 1%. So the basic thing is that you have to create three important things, okay? So in Whipple, it's actually a pancreatic duodenectomy, okay? So you're removing the duodenum, you're removing the pancreas. So the only difference between a pylorus preserving pancreatic duodenectomy and a Whipple procedure is that you're also removing the pylorus of the stomach. But in pylorus preserving pancreatic duodenectomy, the rest of the part remains the same, but you're just also preserving the pylorus. So in case of Whipple's is more commonly performed for the pancreatic carcinomas or periampullary carcinomas or the carcinomas head of the pancreas. But, in case of the extensive tumors of the common bile duct, this procedure can also be performed in case of the common bile duct tumors. So in this procedure, you are doing a hepaticojejunostomy or choledochojejunostomy, then you're doing a jejunojejunectomy, and the third thing you're doing is gastrojejunostomy, okay? And you're resecting the lower part of the pylorus in Whipple's. But in the other technique, which is called as a pylorus preserving pancreatic duodenectomy, you're actually not resecting the pylorus. So you see here, this is the stomach, and you can see the bile duct here, and you can see the gallbladder and the pancreatic tumor here, okay? So sometimes it's not only the pancreatic tumor, but also the common bile duct tumor. So it's actually the retroperitoneal part, and it's behind the C loop of the duodenum. That means it's behind the head of the pancreas, and it's behind the second part of the duodenum. And then you have to resect all this portion. And this is the extent of the resection, okay? So you resect the gallbladder, you do the cystectomy, cholecystectomy, you do the cholecystectomy, and then you also do the pylorus, the resection of the pylorus, or you can say the distal part of the stomach is also being removed, and along with the removal of whole of the head of the pancreas and the whole of the common bile duct and this duodenal loop. So this is actually the pancreatic duodenectomy, in which you're removing the pancreas, in which you're removing the duodenum, you're removing the common bile duct, and you're removing the distal part of the stomach as well. So this was actually, you can see the part of the tumor. It's for the diagram is for the pancreatic tumor, but the bile duct is just behind this. So it's if the tumor is invading the distal part, so you can do this procedure as well. So this is actually the confluence, and this is the choledochojejunostomy, and you are closing this part, the end of the duodenum that is being closed, and this is gastrojejunostomy. You are also removing the head of the pancreas, the whole of the duodenum, the bile duct, and especially the common bile duct, which is supraduodenal and retropancreatic and retroduodenal. And this, you are creating anastomosis between the pancreas, and you are actually doing a pancreatic duodenectomy, and then you're doing a pancreatic jejunostomy and gastrojejunostomy. So you are combining, or you're creating anastomosis between the pancreas and the jejunum, and this loop is being closed, but the other loop is functional. So this is actually the choledochojejunostomy, in which you're creating anastomosis between the jejunum and the remaining part of the bile duct, and you're creating anastomosis between the pancreas, the remaining part of the pancreas, like the body of the pancreas and the tail, and you're combining it with the jejunum as well. And you're also doing the gastrojejunostomy. It's a long procedure, almost 8 to 10 hours procedure, and it's reserved for the tumors which are locally very advanced, like the common bile duct tumors, which are involving the hilar and the distal part of the common bile duct. And these tumors are usually, if we talk about the prognosis, so they have a better prognosis that their surgery is performed properly in an expert center. The survival rate can actually extend up to 24 months. So we have been discussing about the pancreatic, we have been discussing about the common bile duct tumors and their classification and their surgical options, and we tried our best to deliver you the different surgical options we have available. And for that, the other palliative care that includes the stenting and ERCP and decompression and putting the patient on symptomatic treatment.